Now, Jerome, do arthroscopic anchors or sutures have any risk associated with them?
Yes, the arthroscopic sutures that we use today are called super sutures. So they're not made out of the traditional suture that we've been used to. They're made out of a polyethylene, and we're becoming aware through experience that there are a group of patients who either have an allergic reaction to the polyethylene in the suture, or they get debris from the fraying of the suture which causes an inflammatory reaction and can cause a condition called chondrolysis, where the whole articular cartilage of the shoulder joint disappears and they develop arthritis within 4 or 5 years of the procedure. So yes, there is a slight risk. All the super sutures, which are used for all different companies' anchors, have that small risk associated with it.
Kwan, we'll work across the panel. Does a patient's age influence your decision-making whether to go arthroscopic or open with the surgery?
Well, I think, if you base it on the criteria that Jerome's already given, then the age does come into it. I think I have a different patient population to you because I don't tend to see those contact athletes as much. So I actually haven't done any open stabilisations in the last few years, unlike your experience. But yeah, it would come into it. Yeah.
Ivan?
Not so much age, more activity level. So, if you're playing contact sports, I'd agree with Jerome, go open, and I think I've got a tendency more to go to a ladder J for the professional contact athletes, just because it's very predictable and it's got a very low failure rate in that population group.
I must say there's certain populations I'm less likely to go to an open stabilisation, so like a volleyball player or a water polo player, where their reach up behind their head is particularly important. And I found that the open stabilisations are stiffer, which I guess is what you want in a contact athlete. What about you, Jerome? Younger patients? I mean, I've seen a higher redislocation rate in arthroscopic stabilisations done in, people in their, teens, 16, 18, 20. What's your experience with that?
Exactly that. The younger they are, the more likely an arthroscopic stabilisation is likely to fail. I'm not sure whether that's due to their activities. They might be more active at a younger age and they might give up their sport if they dislocate their shoulder at 25, but certainly there is a much higher failure rate. In fact, there's a study done some years ago in South Australia where they looked at Australian rules football players who had arthroscopic stabilisations, and this was in elite teams by good surgeons, and they found that the arthroscopic failure rate in AFL players was something like 60 to 70%. And it was certainly more prevalent in the younger player.
Yeah, all right. Because that's certainly a trend that I've started to see, the younger active patients. I've started to do more open stabilisations for them. Luckily, Jerome taught me how to do an open stabilisation many years ago. All right, Jerome, arthroscopic ladder J as opposed to an open ladder J. What are your... let's just again go down the panel. Kwan, do you do arthroscopic ladder J? Ivan,
no experience with
ladder J?
I do open ladder Js. I think the capsule application and repair components are very important in ladder J, and that tends to be a bit neglected in the arthroscopic procedure.
So what you're saying there is when you do an arthroscopic ladder J, you can't do a capsule application.
They do attempt at the capsule application, but it's not as well. Some people don't just leave the capsule, and I think it's an important part of the stabilisation. Also, if you're not doing the capsule or repair, you've got a piece of bone that the humeral head can rub on, which I think increase the risk of arthritis and bony block procedures, which Jerome mentioned. So I do an open procedure. I think to me it makes a lot more sense.
Jerome?
I mean, just for the physios, when you do an arthroscopic ladder J, to do the operation properly using an arthroscope, you have to actually excise some of the anterior capsule, which is what Ivan's saying in our hands is important to repair, and they just excise it completely. Having said all of that, I think you have to be an arthroscopic gymnast to do this. It's a very technical procedure. The guy who popularised it, a fellow in Annecy in France called Laurent Lafosse, said that in his first 50, they took him 4 hours each. He had lots of complications, so there's certainly a learning curve. I think we'll be doing more of them as the instrumentation and the technique improves, but right now it's hard to recommend an operation that has a high complication rate in very active people who can't afford to have a bum shoulder for the rest of their playing career. Whereas an open Latarjet takes 45 minutes, it's very predictable, except for the nerve damage, and there's more nerve damage in an arthroscopic procedure. So if you ask this question, Doron, in 5 years' time, I think most people will be doing arthroscopic Latarjets.
The other thing about when people first started doing Latarjets, they used to take down subscap, and that created a morbidity of its own. But these days with the subscap split, to do the Latarjet through that split, there's very little morbidity associated with actually doing the Latarjet. And so I think that, as you say, the instrumentation is not yet good enough to do a reliable arthroscopic Latarjet for most people. All right. Now, following the Latarjet, if a patient has had a Latarjet and they dislocate the shoulder, what do you do then?
Well,
Do you, Ivan or Quan, do you want to answer?
The patient's buggered. I mean, I don't want to use the term Dr. Nagreen used this morning, but there's nowhere to go. Well, sorry, there is somewhere to go, but wherever you go then is less than satisfactory in a contact athlete.
It's not an ideal situation when you stretch the imagination. So, but you've got
Just sit forward, Ivan, into the mic.
Yeah, that's a bad situation to be in. So you've got to look at the reasons why it failed. Bone block position, that sort of thing, the degree of trauma associated with the injury. It may be that you can reposition things, although it's a difficult operation going through a very scarred area. When you're doing Latarjet, you want the bony block to be at level with the joint surface. A common mistake is putting it too medially, so it's no longer increasing the arc of rotation that you've got available in the glenoid. And also, one of the reasons why Latarjet works is you've got your conjoint tendon attached to the transferred coracoid. So when you get your arm up in that position, the conjoint tendon acts as a sling reinforcing the anterior inferior capsule. So if the block's malpositioned, that might be so effective. So there's a chance that you can maybe salvage it by moving the transferred coracoid to something more appropriate and then revising the capsule plication. Another option is taking a piece of the iliac crest and using that to reinforce the giving a bony reinforcement to the anterior glenoid, giving a bigger arc of bone to keep the shoulder in position. If you're getting doing that sort of thing, the risk of getting degenerative changes later on becomes quite significant. And there's also sort of Bristow type procedures where you just put a big lump of bone in the front of the glenoid. It acts as a buttress to stop it coming out. Obviously that's not ideal, but it can salvage a difficult situation.
And one of my major concerns is that we're putting screws and bone graft onto the glenoids of young people who are almost certainly going to develop arthritis when they're older, and then we're going to have to start learning how to do shoulder replacements in people that have had altered anatomy, screws and bone on the bone graft, and then perhaps we're stuffing up the shoulder replacements of the future, having done these Latarjets so often right now. And that's why I think Jerome's comments about open stabilisation, filling that gap between arthroscopic and Latarjet is really helpful, because those people can have a total shoulder replacement in the future without too many problems. All right, so if we can do a few housekeeping things. Just first, I guess, let's say thank you to the panel.